And perfect. So I'll hand you over to MedStop, who'll take you through endocrine part 1.
Good. Hi guys. I'm just going to share my screen. So my name is Carl, one of the final years at Cambridge, and going to be delivering the endocrine part 1. Let me just share my screen. Good. So it's quite it's a smaller group. Maybe it's the nice weather, but you guys made the right decision to come. So we're going to basically, you can just put anything into the chat whenever you want to and just ask me. In terms of the content we're going to cover, it's going to be mainly focused around thyroid, but we're also going to carry on into calcium if we have more or less enough time. I'm not going to spend a huge amount of time on sort of the basics or the things that I think a lot of people have learned at the start, but you're very welcome to ask them because they obviously take some time to sort of grasp in the first instance. But I'm also going to put in some slightly more advanced or like tricky concepts, which are sort of logical and will be helpful for sort of exams later on. Okay, so we'll make a start. So the first thing I think that people often confuse, sort of just as a refresher, is just think to yourself, what are sort of the different endocrine organs? There's 3 in the brain, 2 in the neck, and approximately sort of 3-ish in the abdomen that are sort of relevant. And you can just take a moment to remind yourself, think about what it is. So most people are quite quick for the first 2. So people often realize the hypothalamus and the pituitary obviously there. The third one is the pineal gland, which does melatonin, sort of part of your sleep-wake cycle, is derived from serotonin as well. But those are sort of the 3 ones in the brain. Then in the neck, we've got thyroid and parathyroid. And then finally, the tummy, you've got the endocrine pancreas, the adrenals, and the gonads. And so what we're sort of covering today, and we'll cover in the other series, is thinking mainly about that hypothalamic, pituitary, and other part axis. And so you might remember that the pituitary has sort of 5 types of hormone that you get in the anterior pituitary and 2 in the posterior. And those 5 in the anterior, they all have their own axis. So you have the hypothalamic pituitary thyroid axis, for example, hypothalamic pituitary adrenal. And so we're going to today discuss mainly the hypothalamic pituitary thyroid axis. Good. And then finally, the third group was, ovaries and testicles. So I'll start you off with a question just for you guys to sort of ease yourself in and think about if you can remember some stuff about interpreting thyroid function tests. I'll give you a minute for it. And it's tricky, but you can work it out. And if anyone wants to pop an answer that they think is the one into the chat, you're very welcome to. And I'll try and have a look. Okay, so we've got one answer, one potential. Anybody got any other suggestions, and I can quickly discuss it? Yeah, good. Yeah, no, it is MRI head. So I'll explain that for a second. So 62-year-old lady, she's got sort of classical features of hypothyroidism. I'm not going to talk too much about the features of hypo and hypothyroidism because people often get them. Hyper is everything is more. And I'll talk about a few of the exceptions of those, but it's generally more and hypo is generally less. So this person has classical hypothyroidism, weight gain, lethargy, and might also have sort of feeling more cold because she's generating less heat. And the thyroid function tests show TSH, which is the hormone that stimulates thyroxine, and thyroxine itself are both reduced. So that makes us think it's hypothyroid because the T4 is down. And because TSH is down as well, it's obviously not primary, it's secondary because the hormone that drives the production of T4 is decreased, okay? So we think it's secondary. Could it be tertiary? Yes, it could be tertiary as well. We don't really know, but the truth is that tertiary is pretty rare. And if it was secondary or tertiary, it's probably a pathology that's in the hypothalamus or pituitary. And the best way to visualize it is MRI head. CT just wouldn't be good enough for a resolution. So that's sort of the thinking behind it. Good. So the healthy thyroid, so just recap, it sort of is this bilobed organ in the front here. For OSCEs, it's probably useful to know that if you feel a nodule, or if you want to assess if it's the thyroid that you're feeling, is you can ask the patient to swallow. And the thyroid is sort of attached by a ligament to the cricoid and the thyroid cartilage. So if you sort of swallow, the whole thing moves up, and then you know it's localized to the thyroid. So that's useful to know. You'll also find that if the thyroid gets bigger, it doesn't really extend upwards, but it often can go behind sort of the sternum into the anterior mediastinum, and that's really because it's kind of limited from spreading upwards by its fascia. Okay, good. So that's sort of OSCE useful stuff for the thyroid. In terms of, I tried to break it down to simple stuff: 3 hormones, thyroxine, and then the active one, which is T3. Why is thyroxine useful? Thyroxine is the one that you give as a replacement when you don't have enough thyroid hormone. Thyroxine is also the main one produced in the thyroid, but T3 is the most active form, and that's converted sort of in the periphery. Okay, calcitonin. So you might have heard a bit about calcitonin. It does reduce calcium, but it's not that important in regulating serum calcium because that's mainly driven by PTH and whether that goes sort of up or down. Good. So that's for the 3 hormones. In terms of the 2 cells, you've got the papillary cells. These I've sort of put in yellow, and they form these follicles with colloid in the middle. And you've got the medullary cells, which are sort of these gray ones here. And the only reason it's relevant to know these 2 is they're sort of the 2 things that from which the commoner thyroid cancers derive. So for example, papillary and follicular thyroid cancers come from papillary cells, and the more rare medullary thyroid cancers come from the medullary cells. And for an exam, I think it's useful to think about if you have a medullary thyroid cancer, it's often something like, for example, multiple endocrine neoplasia, and it can be sort of a 2A or 2B subtype because they're quite rare overall. Good. What else do I think was useful to know about the thyroid, just to sort of have the basics in check, is obviously it's got iodine, thyroxine, and it's also protein, sort of, it's a peptide hormone, not like a steroid hormone, because it's derived from amino acids. Good, so that's the main stuff to have in your head about the thyroid. So this is kind of the axis that a lot of people know. Got the hypothalamus here, makes TRH, the thyrotropin releasing hormone, anteropituitary. So one of the 5 cell groups is the thyrotropes, and they make TSH. And that then stimulates the thyroid to produce mainly T4, but some T3. And the other thing that's useful to know about endocrinology in general is you always have to think about the free hormone. So total hormone doesn't matter that much because most of it is bound, and the biologically active form is the free one. So does anybody know what the thyroid function tests measure? So if the GP says I'm ordering thyroid function tests, because we have a lot of things that we could measure. And the things that we actually measure, yes, it's TSH, T3, T4, and more specifically, it's often TSH and free T4. And because T3 is expensive, people don't normally measure T3 unless it's really necessary, because free T4 and TSH give you most of the information that you need, and that's sufficient. In terms of thinking about patterns where things go wrong, people are quite quick to figure out if T4 is up and TSH is down, it's sort of a primary derangement. And if it's the opposite direction, it's also a primary derangement. But sometimes you just get a TSH that's off, or a TSH that's reduced or elevated. That's often called sort of subclinical hyper or hypothyroidism. And I think the key thing to get into your head is TSH is much more sort of sensitive at picking up thyroid disorders. And the way that I'd explain that is sort of T4, you have to imagine every reference range you get for a lab value is mapping the population. And T4, anybody can have sort of in the whole population, my T4 might be quite low. Somebody watching this might have sort of a quite high normal T4, but the TSH is much narrower spread across the population. So for me, if my sort of normal went up a bit, then the TSH would be the first thing to change. Does that make sense? And I might not necessarily leave from the normal free T4 value. So to cut the long story short, TSH is really sensitive and the main marker. And if TSH is normal, you probably don't have hyper or hypothyroidism. Cool. Okay. In terms of TRH, the only reason I mention it is also for those if there's any 50ers watching, you've sort of got that consideration about fertility and stuff with thyroid disorders. If you're hypothyroid, primary hypothyroidism, your hypothalamus and pituitary wants to make more thyroid hormone. Hence, it makes more TRH and TSH. And TRH also drives prolactin production. So sometimes people with primary hypothyroidism can get hyperprolactinemia. Good. one question, do you treat subclinical hypo or hypothyroidism, or is it watchful waiting? If it's asymptomatic, it's typically watchful waiting. And if people develop symptoms, then you can treat it, is sort of generally what I use. Good. So I've spoken a lot here. We can do some interpretation now. So we'll just do sort of one at a time. If anybody wants to put into the chat, or you can even unmute yourselves, to be honest. Just let me know what the diagnosis is. So the first one, TSH is up, T4 is down, T3 is down, and thyroglobulin, does anybody know what thyroglobulin is? It's a bit like in insulin. When the pancreas produces insulin, you also have C-peptide, and that helps you figure out whether the insulin that's in the circulation is endogenous or exogenous. Because if the pancreas has made it, it also releases C-peptide. It's sort of part of the making process. And that's the same thing with thyroglobulin. So when the thyroid gland makes thyroid hormone or thyroxine, it also puts out thyroglobulin. So thyroglobulin usually should mirror the endogenous level of thyroxine. Does that make sense? Good. So this one here is primary hypothyroidism. So T4 and T3 are down, TSH is up. This here, secondary, everything is down. This one here is a subclinical sort of phenotype, and that's because the TSH is up, but the rest is sort of in range. And then here I'm basically just doing the opposite. So here you can sort of work out the corresponding values. Now these last two here are a bit trickier, but I think worth sort of thinking about. Does anybody know what this one here, the last two are? So 0 for me sort of means it could be either or. The key thing here is sort of T3 is usually a bit reduced. Good, yeah, so somebody's messaged that the last one is exogenous administration. That's because the thyroglobulin level is low, but you can see that the T4 and T3 is elevated. So somebody's basically just taken a lot of levothyroxine, so some sort of overdose, and the thyroglobulin is depressed. This one here is actually quite common. It's sick euthyroid. I think this one's useful to know because sick euthyroid is basically you're systemically unwell, and that because you're systemically unwell, the concentration of thyroid hormone can become deranged. And the take home from that is you shouldn't really interpret thyroid function tests in people that are on ITU, really unwell with sort of a pneumonia or something in hospital. Yeah, why is it so variable? It just sort of depends how sick you are. And one of the key things is kind of that the T3 is reduced. And I've written a bit about it at the bottom, but I'll just skip over it now. Another question. You can recap your ECGs. Okay, if a few more of you want to vote, or we can just close. I'll give you 27. I'll give you till 45 seconds. Okay. Okay, something's gone wrong. The most of you put. Oh, here we are. I'll share the results. So yeah, most of you put the right one. It's TFTs. So basically, this lady here is 35, so she's quite young, and she's got AF on here. You can't see any P waves. You can see that the QRS complexes are not spaced evenly, so they're irregular. And any person that has new onset atrial fibrillation, you should do thyroid function tests to check they haven't got thyroid derangements, because that is sort of a treatable cause of AF. Good. Now, hypothyroidism, this is sort of primary. I sort of divide it into hyperfunctioning. That means you're just sort of stimulating the gland too much. It can also be gland destruction. So if you destroy the thyroid gland, then you actually release a lot of thyroid hormone. And then finally, it can also be secondary. So secondary is when you have TSH driving, or tertiary, but tertiary is vanishingly rare, so I don't mention it. For your exams and for sort of OSCEs in general life, I feel like mention things that are common. So the top 2 causes of hypothyroidism are Graves' disease and a toxic multinodular goiter. Everything other than that is sort of secondary. It's pretty rare. It's not going to come up that much. And if you forget to mention the first 2, you look kind of stupid, because those are the most important ones, and also they're the most common ones examined. Good, but I put sort of some rare ones as well. Other ones, for example, from gland destruction. These ones here, they often go hyperthyroid and then hypothyroid, because once you obviously ruin the whole gland, you're not going to make any more hormone. Good. And I'm going to discuss the top 2 most common ones, so Graves and toxic multinodular goiter, in the next slides to explain a bit more. Just some general stuff to say. Does everybody know the difference between sort of like toxic and non-toxic? So it's sort of thrown around a lot. Toxic basically means it's making hormone. If it's a non-toxic sort of goiter, then it's not producing thyroid hormone. So we could all have sort of a large thyroid, which is a goiter, but it might be toxic or non-toxic. So that's one thing to get into your head. The difference between a toxic multinodular goiter and a toxic adenoma is the adenoma is just one. The multinodular goiter is basically just like many, multiple. Yeah. Good. Some other stuff about drug-induced stuff. So amiodarone is sort of a commonly used example. It really confuses people. Amiodarone can make you thyrotoxic, but it can also make you hypothyroid. Most people actually makes hypothyroid. Those that it makes hyperthyroid, it has 2 different subtypes. You don't have to know about it. I just think it's good to know that it can almost do anything. So don't be thrown off if you see it in different types of questions. And the reason for that is amiodarone is one of the few drugs that has iodine in it. So actually that's why it interferes with production of the thyroxine, which has iodine as well. Good. Other stuff for like 50 years, obstetric stuff that's useful to know. Beta-HCG and TSH look structurally really, really similar. Meaning, if you have a choriocarcinoma, a molar pregnancy, or multiple gestations, so sort of twins, triplets, you might make a lot of beta-HCG, and hence you might experience symptoms of hyperthyroidism. Good. Graves' disease. Everybody, as I said, often gets the symptoms of hyperthyroidism. You're feeling hot, you have to go to the toilet, you've got diarrhea, tachycardic, high blood pressure, etc. Sometimes people confuse hypothyroid symptoms due to elevated thyroxine with Graves' disease, but Graves' disease has also got this autoimmune component. And I think about these sort of 3 things that Graves does. So one of them is it actually just increases the synthesis because it has these thyroid receptor antibodies. But the second thing that these do is they also increase the synthesis of certain sort of fibroblasts, etc., in the shins, and they give this phenomenon called pretibial myxedema. Another thing that I used to find confusing, myxedema, you might have heard of myxedema coma in hypothyroidism. Myxedema is a hypothyroid state, but pretibial myxedema is something from Graves, so in the hyperthyroid state, if that makes sense. But yeah, it's confusing to sort of hear. Good, so how do we investigate? We'll sort of do our sort of thyroid function tests, do the antibodies. If you have these antibodies positive, you can basically diagnose Graves if you have the TRAB positive. Other antibodies, just sort of be aware of, they could also be positive in Graves. So anti-TPO, for example, can be positive. Yeah, and antithyroid globulin is often positive in Hashimoto's and in Graves. Good. So just sort of some key stuff to think about. So some signs that are Graves specific, and people often think are sort of, though they're just with hypothyroidism, are, for example, the fact that the eyes are popping out. So this exophthalmos, that's actually because you've got more fat, and that's the immune component of Graves, increasing the mass in the sort of ocular space, so it's pushing the eye out. And the pretibial myxedema, as I said. And then also thyroid acropatchy. And thyroid acropatchy is this sort of triad of things. It's clubbing of the fingers, you get this periosteal proliferation and swelling of the soft tissue of the fingers. And it's quite rare, but that's Graves specific. Good. Lid lag and lid retraction, you can just get them in any form of hypothyroidism because that's due to just the sympathetic activity. So that's basically your eyelids are you get basically lid retraction is you get scleral show. So in a healthy human, you shouldn't be able to see the upper margin of the iris. You see that eyelids normally cover it. And if you have Graves or hypothyroidism, it's sort of, the lid is pulled further up and you can see that top. So it often looks why people think people are staring at them. Good. The last thing I was going to say is also lid lag. So lid lag is actually when you look at something, you follow it down, and your lid, normally your lids come down with you, with your eyes sort of. And if they just sort of stay there and they wait, and then they drop, that's lid lag. Good. Okay. Any questions? Okay, nothing so far. So toxic multinodular goiter. Bit of a mouthful. It's toxic, so you're producing thyroid hormone. Multinodular, meaning you have a lot of nodules, and it's a goiter. And a goiter is basically any mass of the thyroid. So funny enough, it often happens because you're iodine deficient. If you're iodine deficient for a long time, your gland is sort of learning to live without. And what often happens is in these glands is they have small little foci that sort of become autonomous at stimulating their own growth. So they become independent of TSH, mutate, and they drive their own growth. And that happens at a few different sites, and then you get sort of multiple nodules. And because they're TSH independent, they make a lot of thyroid hormone, and hence you become hyperthyroid. Good. So the way that you can diagnose these is you can look at a tracer, for example. These are some of the tracer sort of scans that you can see, you might expect to see. So if you look at a normal one here, I'm not sure if you can see my mouse, but it's the A1 there. You can see that there's sort of some uptake of the tracer. It's not too bright. This is sort of a healthy thyroid. In Graves' disease, where you have this antibody stimulating all of the gland pretty equally, you have this diffuse uptake, and it's much, much brighter compared to normal. The thing that you should say about toxic multinodular goiter is you can see I have 1, 2, 3-ish sort of nodules that are really high in tracer uptake. But the rest of the gland is quite reduced. Does anybody know how you would explain that? Why do you have 3 nodules that are really bright with uptake, and why do you have the rest of the gland that's sort of reduced in uptake? Yeah, somebody messaged a thyroid hypoplasia. Yeah, more sort of in the sense of if you have these nodules producing a lot of thyroxine, it's going to feed back to the pituitary to reduce TSH, so you get the primary hyperthyroid picture. And hence the rest of the thyroid that is sort of healthy or behaving itself and not producing thyroxine autonomously is actually going to reduce in size and reduce in how much it produces. Does that make sense? That's why. So I guess you could say it's hyperplasia, but the key thing is that the other one is TSH responsive, and in primary hypothyroidism, obviously the TSH is reduced. Cool. Toxic adenoma, same as toxic multinodular goiter, but just one basically, and just less common, but it's sort of a similar mechanism. Good. So what would you expect in a toxic multinodular goiter? You'd expect all antibodies to be negative. So that's often why people think about it. So they try Graves, they do the antibodies. If all the antibodies are negative, you might do an uptake scan. And if the uptake scan is positive, then you have the most likely diagnosis. Good. Management. Generally, in an exam, you can always sort of give the answer. You want a symptomatic control. And beta blockers are almost always started if somebody's confirmed as hyperthyroid. I've written there so you can read about it, some of the stuff that it does. People also usually start carbimazole or propylthiouracil. Key things to know about those drugs is they inhibit production of thyroxine. They don't destroy the gland. I know that's sort of a misconception, but I used to think that. They don't actually get rid of the gland. They just stop the production of thyroxine. Now, funnily enough, in Graves' disease, which is by far the most common, if you just stop the thyroid producing thyroxine for often regresses and just goes away. So that's why you can give some people carbimazole and propylthiouracil for sort of like a year or a year and a half and then stop them, because it can sort of bridge that gap until the disease remits, if that makes sense. If you have something else, for example, toxic multinodular goiter, or an adenoma or something, that's not going to go away if you just give antithyroid drugs. So that you have to either remove the thyroid or ablate the thyroid, if that makes sense. Good. So that's sort of the key take homes. For an exam, one thing that often comes up with carbimazole and propylthiouracil is either knowing when to give it in which trimester of pregnancy. So propylthiouracil is obviously better in the first trimester, and carbimazole is better in the third trimester. And that's because in the first trimester, carbimazole can give this thing called aplasia cutis. So basically you don't get any skin on the embryo. Good. And then the second thing to know about carbimazole is it can give you agranulocytosis, so drop your neutrophil counts. So to prevent against that, you usually tell patients, if you feel unwell, have a cough or a cold, you should come and get a full blood count. And the full blood count will make sure that your white cell count hasn't dropped off. So that's something that sometimes comes up if somebody's on carbimazole and they're unwell. Good. Question. What was the name of the skin problem in the embryo? So I wrote that it's aplasia cutis. So it just means sort of aplasia, so no development and cutis skin. And there's some other side effects here. No worries, good. So that's sort of, I think that's sort of the main stuff to take home from here. Good. Thyrotoxicosis, rare, really rare nowadays. It would have to be sort of an untreated hypothyroid state. If you make the diagnosis, there's sort of a standard tagline that I've sort of put, which is you give basically the standard treatment, propranolol and carbimazole, to stop the production and to decrease the symptoms. You also give hydrocortisone because it blocks this conversion of T4 to the more active T3. You also give fluids, because they're often fluid deplete. And then finally, you also give potassium iodide. Does anybody know why you give iodine, which is the substrate for thyroid hormone in thyrotoxicosis? So, yes, exactly. Yeah, somebody said it. So iodine actually blocks thyroid production. The thyroid's kind of shocked when it sees so much iodine, so it just pauses and waits. Good. So another question here. Give you guys another, I'm going to leave it for till 50 seconds. Okay. So yeah, so most of you got this here. I actually put this question, it was sort of going in this direction. I put it more in just to re-emphasize some of the findings you can get in a hypothyroid state. So for example, you get a macrocytic anemia. It's one of the differentials for it. So obviously for macrocytic anemia, you have a lot of different things. One of them is just hypothyroidism can just do it. And the other one that you can have is you can get a hyponatremia. So it's one of your other differentials for a euvolemic hyponatremia. So you have SIDH and you can also have hypothyroidism. They're sort of in the same category. Good. Good. So here we are. So here we are in the hypothyroid state. Again, I've just put sort of the common ones here. So you can either the gland is not working so well, the gland is being destroyed, and hence you don't make so much, or you have a problem in the pituitary. I'll just tell you the most common ones again. I'm going to talk about Hashimoto's, congenital, and I also added in thyroiditis just because it can come up in an exam again. Good. Cool. So Hashimoto's, what do you want to think about there? It's autoimmune again. It targets a similar receptor sometimes. The most common positive one is anti-TPO. As I mentioned before, because you can have anti-TPO positive in Graves', it means it's not specific. So if you have anti-TPO positive, you can't say this is a diagnosis of Hashimoto's. It's in the context of it being primary hypothyroidism. Congenital, for those having obstetrics again. So this one here, you do a heel prick test at 6 days, and you look at the TSH. So you would expect that the TSH in a congenital hypothyroidism is actually elevated. And it's often sort of a spontaneous thing that happens. And it's important to screen for, because mum basically produces thyroxine for the child until it's born, and then it's suddenly gone, and the child can get sort of intellectual problems if it's not treated. Good. And here you can see, you can basically see here in this histology slide, which you don't have to understand, but not that I understand it either. It's basically just to know that in Hashimoto's, and a lot of them, you get these follicles, you get this lymphocytic infiltrate that forms these secondary lymphoid follicles. Good. Oh yeah, somebody wanted to go back to the previous slide. I can quickly, sorry. I think it's probably easier if I just continue for it and you can have a look at it on the recording. Good. So viral thyroiditis often follows this thing. So often goes thyrotoxic because the virus is destroying the thyroid, so it's tearing open all the cells. Then it will go through sort of a euthyroid state and then into the hypothyroid part, and it'll often recover itself. So the key thing to know about this is you'll have the viral prodrome in the history. You might have an elevated ESR, CRP, sometimes leukocytes, and management is just self-limiting and just take some NSAIDs. Good. So for all hypothyroid conditions, you take levothyroxine. Levothyroxine, is T4 basically, and that does the trick. It has to be titrated, so sometimes you measure the bloods and adjust it. Mixed edema coma is really rare, but serious. And the way that you basically think about this here in an SBA, and this is, again, rarer to come up, is you want to think about replacing the thyroxine. And the only other thing to think about is, so sometimes people that have autoimmune hypothyroidism, they also have other autoimmune conditions. So in an SBA, they'll often try and trick you sort of into what to start first, and you have to think about putting in a cortisol, for example, hydrocortisone, because you have to replace cortisol before you place thyroxine. We can discuss that in another talk. So you can try this one here, number 4. Okay, I'll just give you guys 15 more seconds. I'll close it now. Good. Okay, so yeah, that is the correct answer. Ultrasound next. So what you have to think about is there's a lump, and what you always want to figure out with any thyroid condition is the TFTs are normal. So that's often the first step in investigating. And the next thing you want to rule out is if you have a lump in the thyroid, you want to exclude cancer. And the best way to exclude cancer is to characterize it. And ultrasound can help you figure out, does it fulfill certain criteria which make you think it's malignant, or it might not? And in which case you can just leave it be and watch for waiting. Does that make sense? So whereas sort of a biopsy directly is too invasive. It's not necessary because there's so many thyroid lumps that you'd find otherwise. Good. So this is sort of a summary I've done here for you guys, or I've used previously. I just put it in here. Basically, you can think about, normally you're going to do your thyroid function test, your TSH and free T4, and you're either going to find somebody sort of hyperthyroid, hypothyroid, euthyroid. And then if they're hyperthyroid, you'll usually think, is it a diffuse goiter you'll do the thyroid receptor antibodies and you'll find out it's Graves'. If it's nodular, you have to think to yourself, is one of the nodules malignant? And hence you often have to do an uptake and ultrasound. If they're hot, it's generally a good sign. So hot nodules make you think it's less likely to be cancer. If they're cold, it's more likely to be cancer, which can be a bit counterintuitive. So if they're hot and you diagnose toxic multinodular goiter, you have the definitive options we spoke about. If it's cold and it's a cancer risk, you'll have to biopsy it. Good. And here you can sort of do the same pathway here. So what? Could you repeat what you said earlier about swallowing and lump in the throat moving upwards? Yes, I'll just do that in a minute. So once I've explained this slide. So here, and if you have a nodule basically and there's no derangement, then you again have to ultrasound and figure out, is it suspect, biopsy, is it not suspect, monitor. So it takes a bit of figuring out, but it's quite simple once you've done it. So this is my other summary here. Basically, what you care about in the thyroid is it cancer and have you got a hormone problem? So you'll check the hormone problem by doing TFTs where indicated. And if you have a lump, you should try and exclude cancer by characterizing with ultrasound or figuring out it's a hot nodule and sort of an uptake scan. Yeah, and here I've put other stuff just to sort of get into your head about there are lots of other things that can be deranged in the bloods when you have hyper or hypothyroidism. It doesn't always mean that, it doesn't necessarily mean that they have another condition going on. It could just be part of the hyper or hypothyroid part. What I said earlier about swallowing the lump in the thyroid. Yeah, so the thyroid has this sort of, it's in the pretracheal fascia, and there's this ligament, I think it's called the ligament of Berry or something, and it attaches to the cricoid cartilage, and that is linked to the larynx. So when you swallow, the whole thing moves up. So if you put your fingers when you're palpating the thyroid and you swallow, you can feel the whole thyroid gland move up, and that helps you localize the lump to the thyroid. What factors in the history suggest thyroid cancer in that patient? So this was, I wasn't trying to suggest thyroid cancer here, so it could just be sort of something benign. So a lot of people have sort of benign cysts. Good. So that was thyroid. Does anybody have any question? That was sort of quite speedy about the symptoms. One thing I will just quickly mention since we're here, I mentioned that most people often get the hypothyroid and hypothyroid symptoms. One or two that are counterintuitive and go against is the one relating to menstrual symptoms. So actually, when you're hyperthyroid, you actually get lighter periods, and when you're hypothyroid, you often end up getting heavier periods. And the reason for that is just the thyroid binding, basically your sex hormone binding globulin changes, and if you're hyperthyroid, your sex hormone binding globulin goes up, so you mop up all your estrogen, hence you bleed. You have less sort of intense periods. If you're hypothyroid, your sex hormone binding globulin goes down, hence you have more estrogen sort of floating around, and you get more pronounced proliferation of the endometrium and hence shedding. So that's a bit complex, but just basically remember that one's the one that's opposite to sort of what you might expect. Good. Okay, so then another question. So I'll just wait a bit longer and give you guys, yeah, another 10, 15 seconds. This is a tricky question again, but I think you can work out, think about what's been happening. Okay, I'll close the poll now. So this person's got thyroidectomy, thyroid. There's 4 little glands behind the thyroid, the parathyroid glands. if you have the surgery, you risk damaging them. And so this patient is otherwise well, and if you wait afterwards, they get this cramping, and cramping is sort of is a sign of hypocalcemia, which is what I'm alluding to with the question. So basically, do the serum calcium because they might be hypocalcemic because you've damaged the parathyroids. And if you don't produce enough parathyroid hormone, you will become, if you damage the parathyroids, you won't produce enough parathyroid and you will become hypocalcemic. And this leads us on to our next topic, which is calcium and calcium homeostasis. We might not manage to cover all of it because I want to stick to the time, but if we don't, we can always continue in part 2, and this will be sort of getting the physiology into your head. It's quite, again, heavy going stuff, calcium physiology. Good. So in terms of hypercalcium and hypocalcemia, I think everybody knows the hypercalcemia, stones, bones, groans, psychiatric overtones, etc. Just to add a few things about what's causing them. So stones, too much calcium supersaturates the urine, forms stones. That makes sense. Bone pain is actually not really due to the calcium being raised, it's just due to the common causes, which is either parathyroid hormone eating away at the bone or a cancer eating away at the bone, hence, sucking the calcium out of the bone. Thrones, so people get polyuria, they pee a lot. That's because it basically gives you a nephrogenic diabetes insipidus. So you're not sort of responding to ADH. So you just pee out all of your water. And that's the same as, if you remember from our last talk, hypokalemia, and lithium can do that as well. Good, and it can shorten your QTC. It can also give you pancreatitis, another bit of a mind boggler, because it can give you pancreatitis, and if pancreatitis is really bad, it will give you low calcium. Fine, okay. In terms of hypocalcemia, you get tetany, so you get Trousseau sign, which is sort of if you inflate this blood pressure cuff and you leave it inflated, you'll sort of go into a sort of spasm. And if you tap sort of around the distribution of the facial nerve, you'll get twitching on that side of the face. The reason for that is it's a bit harder to understand from first principles compared to sodium and potassium, but calcium basically inhibits voltage-gated sodium channels. So if you reduce the calcium, you actually relieve the inhibition, and hence everything's a bit more excitable. Sorry, could I repeat what I said about pancreatitis? Yeah, sorry, again, a lot of information coming at you. So basically, raised calcium can give you pancreatitis. It's one of the causes in your mnemonic of get smashed. If you get really severe pancreatitis, you can get hypocalcemia, and that's because all the enzymes that you activate in your pancreas, they basically saponify, and they basically pair up with calcium in the blood because it's a cation. So if you form lots of anions, you can sort of pair them up, and hence you sort of draw out the calcium. So cut the long story short, if it's really high hypercalcium, you can get pancreatitis. And if the pancreatitis is really bad, your calcium goes down, okay? Because sort of the activated enzymes leach all of the free calcium out. Good, okay, so that was a lot of info in there. So I've tried to make it as simple as possible. So we've got the calcium 1, 2, 3. So there's one organ that sets sort of the tone. There's 2 compounds that bind free calcium, and there's 3 organs that actually manage sort of the calcium levels. So if you want to think about it, does anybody know what is that one organ that does the whole threshold, does the main monitoring? It's the parathyroid glands, obviously. So then the 2 compounds that bind calcium is a bit of a tricky, yeah, sorry, thanks. Who answered the parathyroids? And what are the 2 compounds that bind free calcium? One is albumin, that's really good. And there's another one, this other inorganic anion phosphate. So phosphate and albumin are the 2 main sort of things that bind calcium. Good. And then there's the 3 organs that regulate, so that's the gut, the kidneys, and the bone. So here it is, sort of in a summary. So you've got these 4 little bilateral paired organs sitting behind the thyroid, sense the concentration, and PTH has to always be secreted to have a minimum calcium concentration. If it drops, so does your calcium. If it goes up, so does your calcium. Albumin and phosphate is an interesting one to think about and to have in the back of your head. Why is it helpful? Albumin, there's a lot of it, obviously, and what you normally get when you're reading your calcium value is you usually get a corrected calcium. That is corrected for albumin. If you're in a low albumin state, that means you'll bind less calcium, and hence your effective free calcium is raised, but your total calcium might sort of be reduced, if that makes sense. You have to always correct for the albumin concentration. The second time that albumin is interesting to think about is when you have acid-base disturbances. So basically, calcium competes with H+, so hydrogen ions, protons, to bind to albumin. The more H+ you have, the less space there is for calcium. The less H+ you have, the more space there is for calcium. Hence, when people hyperventilate, when they have sort of a panic attack, for example, they become alkalotic. If they become alkalotic, that means they have reduced H+, hence more calcium binds onto albumin, hence your effective calcium drops, and you get these symptoms of hypocalcemia. So you get tingling around the lips, you get tingling at the ends, tips of the fingers, and that's actually got to do with an acid-base disturbance. Good, so again, a bit sort of complicated, but it might help you remember and make the link that when you're hyperventilating, you actually get symptoms of hypocalcemia. Good, and then the three organs, which I will touch upon briefly. I think the three organs, the thing to sometimes get your head around is, what do they do to phosphate and what do they do to calcium? So the aim of all of these organs is to raise calcium. So it's unsurprising that the gut, the bones, and the kidney all work towards increasing calcium. There's a few other things though. So phosphate, if you really want to increase calcium, what you want to do is you want to drive down phosphate, because the less phosphate you have, the more effective calcium you have. So that's what the kidney does. The kidney excretes phosphate. The bones and the gut, on the other hand, they're a bit different. They actually increase the absorption or resorption of phosphate. So those are the ones that they actually increase phosphate, but the kidneys try and get rid of it. The net effect is, if you increase your parathyroid hormone, you increase your calcium and you actually drop your phosphate. Good, and that's sort of put some of it here. So here's the parathyroid hormone. If you can see my cursor, if you sort of read it with me, you go to parathyroid hormone, it goes down, it acts on all the organs, but parathyroid hormone doesn't act on the gut directly. That it does via vitamin D, activated vitamin D. And vitamin D then acts on the gut, and it also acts on the bones to raise calcium and phosphate. So I've got a question. So the net effect of all the organs. So the net effect is, if you raise parathyroid hormone, you raise calcium and you decrease phosphate, because the kidney chucks out the phosphate, and that's sort of the predominant effect. Does that make sense? It's also logical, because what your body's trying to do is if it's increasing PTH, it wants to increase calcium. Hence, it makes sense to jettison the phosphate and retain the calcium. Good. So there's a lot of other random stuff here that I put here that you can just have a think about. How does this matter for your SBAs? So let me just bring it back to something that's relevant. They will rarely ask you if it's the real calcium. So in clinical practice, you have to think about, is this calcium a true reflection of the free calcium? So you'll have to check, is there an acid-base disturbance? If there is an acid-base disturbance, you should probably get a VBG calcium or an ABG calcium. In an exam, they're not going to try and trick you by giving you a fake calcium value. What they will do in an exam is they will expect you to figure out what the causes of the hyper or hypocalcemia. So I'll just skip ahead quickly, and we can do one or two other questions. So I'll give you guys another 15 seconds. Okay. So is PTH levels correct? Good. So what's happening here? This person has all the symptoms of hypercalcemia. He's also got some background medical histories on certain drugs for hepatic encephalopathy, for example. That's the rifaximin and the lactulose. The calcium is up, the phosphate is down. So this is a classical sort of picture of parathyroid hormone or something sort of driving the calcium to go up. Now, we don't actually know what it is. It could also be malignancy. It could be a lot of different things driving the hypercalcemia. But the logic here is what's the most helpful thing to do next? And that's to check what are the levels of that master regulatory hormone, parathyroid hormone. And that's almost always the first step when you're trying to assess the cause of a confirmed hyper or hypocalcemia. So hypercalcemia, top two causes, if you take nothing else away, remember that the top two causes are primary hyperparathyroidism and hypercalcemia malignancy. Together, they are 90% of everything you're going to get. Good. In terms of hypercalcemia malignancy, there's a broad, again, it's a bit confusing. There's a few different things to think about. Either it's metastatic, and I've listed here the top 5 metastatic causes. So some of them are familiar, probably prostate, breast, lung, thyroid, and renal is sometimes less familiar to people, but you'll remember them over time. Those are the top 5. If you ever want to remember them, that's the list you should know. For blood cancers, you think of sort of lytic things like multiple myeloma and lymphomas. And in an SBA, so that I know somebody put urinary Bence-Jones proteins on the previous one. That's what you do for multiple myeloma. You wouldn't do it first line, and multiple myeloma in an SBA often comes with this sort of 4 core features. It'll be sort of anemia, symptoms of hypercalcemia, a fracture of some sort. Yeah, and you can sort of get these lytic lesions. Good, and then lymphomas can also do it. Now, some cancers actually have parathyroid hormone related peptide. They secrete that, and parathyroid hormone related peptide is not the same as parathyroid hormone. The key thing to sort of stress here is if you measure serum PTH, you won't pick up a raised parathyroid hormone related peptide. That's why they label it differently. So if you had a cancer producing parathyroid hormone related peptide, the PTH would actually be decreased because it's trying to counteract the rise in calcium. Does that make sense? So it's not quite the same as an SIADH, for example, because parathyroid hormone related peptide is actually not measured by the PTH assay. Good, so that was a lot of stuff to say. And then there's a few other ones to get your head into, and probably don't have quite enough time to explain to you what the mechanism is of all of these. Thiazides are one of the drugs, and they're the opposite to furosemide, loop diuretics. So thiazide diuretics raise calcium, loop diuretics reduce calcium. They have a different mechanism of doing that. Good, and granulomatous disorders. So this one here, I think is quite a neat one to sort of, if you want to remember, I'll just tell you now quickly. Basically, granulomatous disorders, they hydroxylate the sort of cells that the macrophages, they can hydroxylate and activate vitamin D. So in granulomatous disorders, you autonomously activate vitamin D, bypass the kidney, and hence you get hypocalcemia. Good. So that was a lot of information that I've just dumped on you. Good. Great. Okay. So that's most of the stuff here. That I think I'll just pause there because it's sort of the hour, and I think if you guys are happy to stop there, then we can continue this sort of next time. And we can repeat some of this stuff. Oh, yeah, I'll see if there's anyone who has a message. Yeah, and if you guys can put out the feedback form, that would be great. And then you can also let me know if there's anything else you want to cover. So we've done this session here. It's been probably a bit more in depth about certain stuff than previous sessions. Other ones you get, you can let me know in the thing if you prefer that, or if you'd rather have it obviously at a simpler level, because yeah, you know, you can do everything. You can keep it basic, or you can just try and also take it a bit more advanced, and it obviously has like its merits in different ways. Oh, great. No worries. Okay, that's good. Yeah, so I think the slides, I haven't made them. You're happy to have them if you want to. I think the recording is going to be made available. I'm not quite sure where, but we'll make it available.
Okay, perfect.
I'll just move into the feedback. There, you can scan this code if it's easier. Cheers.
Thank you very much, Carl. That was really interesting and really good to go through some of them. I definitely need to revise a lot. I've just got a little thing from us about coming up and coming sessions, if that's all right. So we're continuing to support the Essential Investigation series. So we've got ECG Part 2 next week, I think, if that's all right. And then just need to sort of mention about the Norwich Undergraduate Surgical Society Conference that's looking to explore equality and diversity among surgical specialties. So that's coming up on the 1st of May. So we definitely recommend having a look out for that. And then for any Norwich students, Norwich medics in the call, scrubs are available from the room of requirement, and the details are via our social media accounts. So get in contact there. But other than that, that's all from us. From MedSoc. Any final points from you, Carl?
No, that's good. If anyone has any questions, let me know.
Wonderful. I'll end the recording there.